Okay, good evening, dear professors and colleagues. It's my honor to me to share with you my presentation. First of all, I'd like to say happy Ramadan for everyone. And this is my presentation for today. Do you see my presentation?
Not yet.
Okay.
Share the
Share
slides, Dr. Vic.
screen.
Okay. Sorry for share screen.
Yes.
Do you see now?
Okay.
Clear, but go to slideshow. Okay, اتفضل.
Okay. This is my presentation about osteoLLD selective intervention. This is still a debate or a disaster. It speaks about the debate for the only osteoLLD or just go to for direct left main LAD. This case series is we have collected it from several months, and let us see the hero of our story. The very first story needed to be rescued as early as possible. She is 40 years old female with no history of risk factors or any risk factor for coronary artery disease presented by anterior stem. She is only young lady, 40 years old with anterior stem. This is her coronary angio. To summarize, we have here osteoLLD lesion. Either to go to an anterior STEMI direct stenting to ostial LAD or go to for left main LAD. Of course, the long-lasting debate. The decision here with the operator was to use the ostial LAD stenting. And during insertion of the stent here, he noticed some heaviness present in the ostial LAD. Thanks God, he finally chose to have a wire in LCX. And after deployment of the stent in the ostial LAD, as you see here, the dissection extended up to the left main and the LCX, and he lost his patient as a going to lose his patient. The patient started to be hemodynamic and stable, and he decided to take left main stenting to the LAD. And here, after left main stenting, we can appreciate here the section in the LCX still present. So he stopped here to do LCX stenting or not. He decided that this patient actually it may be some sort of vasculitis, and he's having as a patient is in dynamic stable. So what to do? He decided to continue for provisional stenting, get out the wire of the circ, and decided to do follow-ups of the patient. The patient finally survived the TIMS3 flow, it's LAD. He took the patient after 6 months follow-up. This is her coronary angio. The LCX has no dissection. And actually, with the workup of the patient, it was discovered to be some sort of vasculitis. Here of second story here, 6 years old patient smoker, hypertensive, presented by STEMI. He has no ischemic, but not medical treatment. Actually, his medical treatment usually is not every time. Here's coronary angio, unfortunately, the operator here has only 6 French catheter. I was present in this case. And was asked to intervene after this third slide. You can see, appreciate, he finally, thanks God, he put wire in the LCX, and after putting a stent 3.5, 25 in LED, we can appreciate here what happened. Missing of the ostial lesion. I was asked to intervene in this case. It was not everyday work. You have only 6 French catheter, you have left main bifurcation, and although you have to go for stenting. Rapidly, we decided to take left main LED stent to rescue the patient who has severe chest pain. Unfortunately, the wire of the LCX is present, so we decided to do left main stenting. After doing the left main stent, the coronary angio, you can appreciate it looks well, but the patient still had chest pain, ST depression still present, so the decision here was to do the LCX stent. So we preferred to tap, but unfortunately, the balloon didn't pass well. Of course, we have only regular 6 French catheter. We did the LCX stent, and also to do just like modified tap, a new balloon inserted in the LCX stent, and another one 4.15 in the left main, and finally, after both, the left main appears well. Of course, we didn't stop here. We, of course, arranged the patient just for the follow-up. My question here, the LCX stent, if one, what is the size of stents that can be done here? 2.5 or 2.75? We can appreciate the size of the LCX. I think it's appears to be sizable. Here is this patient, we decided to take 3.48 stent, 3 stent and inflated in and 3.5. We took the patient for follow-up after 6 months. You can appreciate the osteal LCX. Do you hear me? This is the osteal LCX.
take your time to explain.
Yeah. Of course, we had a bail-out technique. We have unplanned left main intervention. We got the patient after 6 months. You can appreciate him the osteal LCX tight lesion with chest pain, severe chest pain of the patient. Regardless, the patient was on one tablet of ticagrelor once daily, but it is some sort not related to the patient. I think it's related to the procedure. So we decided to do IVUS for the follow-up in this patient. And here is the surprise. This is the LCX diameter. The LCX can capacitate up to 3.57, and the stent 3 diameter stent only expanded to 2.9. This is the first thing that happened. And of course, the the left main stent is opened up to 4.3, and the area here is much more bigger. So we decided to do drug-eluting balloon at the NHI in this area. Of course, we have pre-dilatation well by regular balloon 5 and 4 in LED, left main LED, and also doing both final casing by drug-coated balloon. And this is the follow-up result for the patient. Actually, we get him after 6 months again, and for this lesion, this appears the same. Of course, it costs us very, IVUS and also drug-coated balloon just for unplanned left main stenting. Or can you do, if you are planning to do it from the start, you will make something good for the patient for about 1 year. This is the follow-up IVUS, 3.54. And this is the diameter of the osteal LCX, which appears geographically to capacitate 2.75. Now we can see in the IVUS it is 3.5. And also the left main stent was 4.5, with lung burden less than 40 and total area more than 6 in the left main. Third patient was proximal total occlusion, anterior STEMI, 50 years old, hypertensive smoker, coronary angiography showed total LED occlusion plaque. This is actually proximal regular anterior STEMI, and this patient's operator decided to do just pre-dilatation for the proximal LED, and he is not planning to intervene for left main LED. But after the operator had balloon dilatation and inserting the stent, we can appreciate some sort of what's called like dissection here in the proximal LED. Unfortunately, he proceeded for stenting of the obvious plaque here in the proximal LED, and we can appreciate the LED is going to have faint flow here. So we decided again to intervene for left main stenting. Here we didn't put a certain wire, although it's necessary, but the angle appears to be more than 120. But it was successful left main stenting, provisional stenting, and risk observation in acute situation. And this final result, and this is the follow-up picture after 6 months. My message from these 3 case series: osteal LED artery should be considered as left main intervention till proved otherwise, because there is nothing called separate plaque between each other. The distal left main is the continuity of it is a LED. LED is ابن الشرعي left main. Selective osteal stenting is very risky, especially when intravascular imaging is not available. Even in emergency cath lab, you have to be prepared with intravascular imaging. Even if angiographically apparent healthy osteum, it may have concealed plaque. So it can convert the procedure to complex intervention, as we saw in these 3 cases. IVUS or OCT are backbone for coronary intervention, and the availability will convert the simple procedure to complex PCI intervention. Thank you very much for you.
Thank you very much
شكرا دكتور فيكتور.
for the discussion to my brother Professor
هي
سليم.
دكتور باسم،
أيوة فندم.
انا بس عاوز اقول تعليق على الاوستيال ال اي دي ليجن، سواء كانت في الاكيوت سيتويشن او حتى بنعمله كرونيك. لازم ايفس، لازم ايفس لسبب، لان بتحصل اندر ديبلويمنت اوف ذا ستنت. يعني هو زي ما فيكتور عرض في الحاله الثانيه او الثالثه، لقى بالايفس ان الستنت اندر ديبلويد، يعني في سبيس، وده عمل الليجن اللي هي جات له اوستيال سي اكس. فهو لازم ايفس، يعني احنا لازم طبعا اف افيلابل، يعني اف افيلابل، بس احنا ما نستهترش في قصه الايفس. لو احنا هنعمل اوستيال ال اي دي، ان احنا نحط ستنت في الليفت من ال اي دي. فعشان كده بيتهيألي الرساله الواضحه جدا ان احنا ما بنبقاش عارفين في اثيروما او لا في السي اكس لو هي بايفركيشنال ليجن. وتاني حاجه ما بنعرفش الستنت هتديبلويد ويل او لا. فعشان كده لازم ايفس، لازم جايدد بالايفس، يعني ده مش هزار، ويتهيألي ده لازم نعمله في كل الحالات اللي فيها اوستيال ال اي دي، وهنحط ستنت ليفت من ال اي دي.
Thank you very much, Dr. Helmi, for your valuable comments. يعني before I leave to lead the discussion by Professor Muhammad Salim, I want to introduce a colleague and friend, Professor Antonio Saatalla, one of the Tuyur al-Muhajra in the States. He's an interventional cardiologist at St. John Hospital, Detroit, Michigan, and the assistant professor of medicine at Central Michigan and Michigan State Universities. Welcome, Antonius. Our first presentation was by Dr. Victor about ostial left main stenting, especially in the acute scenarios, and he had some follow-up of the patients, and I will leave to lead the lead for my brother Professor Muhammad Salim, one of the interventional cardiologists, biggest interventional cardiologists here in Egypt. He will lead the discussion with Professor Victor and other colleagues. Professor Salim.
Thank you, Dr. Basim, and thank you, Dr. Victor, for your presentation. Although you presented 3 cases, but I think the 3 cases are not similar at all. For the first one, there is an extension of the dissection to the LCX, and the operator was very courageous enough to leave this dissection without any intervention. And the patient was also lucky enough that nothing serious happened on the follow-up angiography. This is the first case. The second case, I think it's completely different story about the instant ostial LCX restenosis due to improper deployment or under deployment of the LCX stent. And in this case specifically also, for the final IVUS you have displayed, there is still an area of mal-deployment between 12 o'clock to 5 o'clock without, there is a gap, and also it needs more dilatation or bigger balloon. And my question here in this case especially is about after IVUS interrogation or IVUS imaging, you displayed the image of kissing balloon directly. Okay, how can you select the size of the kissing balloon, and if you at that time go for the sequential ballooning for each one to correct for the under deployment, and then you will go to the kissing balloon. I'm sorry, there is still some noise. I want to know where is this noise from.
First of all, my message, excellent, Dr. Salim, for your comment. Of course, my message in these 3 cases, I think these cases should be done for left main LAD stenting from the first, and also preparing for left main 2 weeks. The 3 cases, of course, are not, of course, complication from just selecting ostial LAD. So the problem here, if you are afraid from left main stenting, you can see in these cases the problem is more and more complex. So don't be afraid from left main LAD stenting. First, answer first question. Second one, for sake of time, we illustrated the kissing balloon. Of course not. Guiding of the IVUS, we knew that the LCX capacity up to 3.5. So we got regular non-compliant balloons for left circumflex, and also also put by 4.5 for left main. But these are the last image, and fortunately in NHI we had this era drug-coated balloon for also 3.5 in the LCX. The last image was for drug-coated balloon, but it is not all the steps we have done. We have, of course, pre-dilatation guided by IVUS. This is answer for your question, Dr. Mohammed.
Thank you, Victor. And